Hello, I'm Ed Draper, and thanks for watching. With this video, we're going to explore the use of ketamine for the pre-hospital setting. Ketamine was created in the 1960s. It is a dissociative anesthetic, which is classified as a Class 3 controlled substance. It is an NMDA receptor agonist similar to propofol, etomidate, and nitrous oxide. It offers complete sedation, analgesia, and amnesia. Unlike other sedatives, patients who are given dissociative anesthetics may remain awake but are not conscious. Their brain is still on, but their limbic and cortical pathways are completely disconnected. Sedatives often negatively affect a patient's hemodynamic status. Ketamine, however, has sympathomimetic properties, which cause an increase in blood pressure, heart rate, and bronchodilation. Ketamine is a safer drug to use, as larger doses will only prolong the dissociated state for the patient, as their body will then take longer to metabolize that medication. It does not mean that the crew should deviate from the idea of crew resource management, where they confirm the patient, time, drug, dose, and route with their partners before administering it. Ketamine is a dose-dependent drug. Lower doses, such as 10 to 20 milligrams, are good for analgesia. Mid-range doses, also known as subdissociative doses, begin to cause hallucinations and can send the patient into a state of vivid nightmare-like dreams, sometimes known as a K-hole. Higher doses, or dissociative doses, upwards of 200 milligrams or 5 milligrams per kilogram, will dissociate the patient's limbic and cortical pathways in their brain, and they will have no recollection of what is happening. Approximately 15% of patients may experience psychiatric distress, especially if these patients have schizophrenia or bipolar disorder. The chances of this happening will decrease with comfort just prior to induction, by aiding the patient in thinking of happy thoughts and experiences prior to the medication administration. When ketamine is given, a patient has to pass through each stage of the effects on their way into the dissociated state. When a large bolus of the drug is given, it decreases the time on the way into this dissociation, but they will still have to pass back through these stages on the way back out. It can be very scary for the patient, and a calm, reassuring voice may aid in their path. If you intend on rendering a patient dissociated the whole trip, it is best to not let them pass back and forth through these stages. Small doses of Versed may be requested for medical control to provide amnesia during that transition. In the Northwest Regional Medical Control Authority of Michigan, ketamine was placed in the pharmacy kits as part of the excited delirium protocol. When utilizing it for this purpose, it can be administered at 5 milligrams per kilogram IM pre-radio as a standing order for the first dose. Ketamine also has been studied and proven to be quite effective for induction, post-intubation sedation, general analgesia, and even given to severe asthma patients who may shortly be receiving an endotracheal tube. If the EMS provider intends on using it for purposes outside of the excited delirium protocol, online or on-scene medical direction must be obtained prior to its use. Excited delirium is an emergent psychiatric condition that can happen to anyone, but most often is found in males in their mid-30s. When it occurs, most often it happens to individuals who are having an exacerbation of their psychiatric condition or a history of using stimulant drugs such as cocaine, Ritalin, PCP, meth, or other amphetamines. These patients have manic episodes which can be constant or come in waves. During these manic states, their adrenaline is pumping. They have superhuman strength and are impervious to pain. These patients can become paranoid, very aggressive with violent outbursts and bizarre babbling and/or shouting. They typically become hyperthermic and end up removing all of their clothing. Due to their unbelievable strength and resistance to pain, it is not uncommon for tasers to be minimally effective or not effective at all. These patients run a high risk of sudden death. They often have elevated levels of dopamine and other neurochemicals in their brain, resulting in an increase in metabolic activity. These patients become acidotic from all of that extra muscle activity and subsequently become hyperkalemic. These two problems can result in dysrhythmias and death.
Auto gave me 911.
Hi, something's wrong with my son. I'm on 1103 South Jefferson. I don't know whether he's 29. I don't know whether he got onto something. He's just, very strange.
Okay, does he need an ambulance? What are you reporting?
I don't know. He's just talking and talking and saying he's going to die, and he's just making like he's on something. I don't know. You hear that?
Does he live there?
Huh?
Does he live there?
Yes.
Has he been drinking?
I just got home a little while ago, and took a shower. He was sleeping. I think he must have.
Does he use drugs?
He used to. He hasn't for he used to do marijuana. He hasn't for years. I don't know whether. I don't know. I don't know what's happening.
I mean, he keeps yelling and says he's dying. Does he say anything else?
No, he just says, I'm dying, Mom, and he's sitting there naked. He certainly doesn't do that in front of his mother.
Okay, we are dispatching help, okay?
Yep.
I want you to tell me if he does anything else.
Yeah, he's just kind of sitting on the floor screaming.
But you don't know if he's used any drugs?
I don't know.
Okay.
It sure looks like it. I don't know.
You want to know about it, Mom? You want to know about it, Mom?
I'm getting you some food.
Even when I know about it, Mom. Even when I know about it.
9128 and 9218.
9128. 9228.
You can help out with a southern complaint. RP's 29-year-old son is acting strange. He's yelling and does currently not have any clothes on. No weapons, unknown intoxicants, unknown drugs. Keeps screaming that he is dying. He's breathing heavily and has no clothes on. Code 3.
9102.
Go ahead.
Dispatch Gold Cross, non-emergency at this point, just to stage in the area. Give them the behavior signs we have at this point. I'll be around as well. Can you talk to your caller, just see if he has any past drug history or mental illness history?
9102, the only thing the RP is aware of is he used to use marijuana years ago.
Okay. I'll be in the area.
I'm clear.
What? Pull me all with 102.
Hi, it's okay. It's okay.
As I'm not.
It's okay.
As I'm not. This is the last heartbeat.
It's okay. It's okay.
But I'm going to
I understand.
not. Is it gonna die? But I'm going to. Is it gonna die? But I'm going
You're
to.
okay.
Is I'm going to die?
9102 restrict traffic.
Beats.
But
It's okay. What is his name? Tim?
Die.
Tim, we need to go to the hospital.
But I'm going to.
9102.
Wow,
Have
and
Gold
this is
Cross
a
come up
really
to the
weird
address.
one, because I'm
1033
not
at this
die,
point.
But I'm gonna hear the heartbeat.
Yeah.
Of
What's his
me
first name
saying,
again?
Oh, I'm going to die.
Tim.
But I'm going to lay down on the ground.
Can you lay down
as
for me?
I'm going to die. But
Tim.
I'm going to
Tim.
not, and you understand now. And isn't that fucking weird? But I'm going to.
Tim.
Is I'm gonna die. But I'm gonna look around. As
Tim.
if I'm gonna die. Shivers are gonna kind of running up my
Tim,
side.
it's okay, ma'am,
I'm not gonna be
ma'am,
able to say
ma'am.
that, but you're gonna
At
know
this
what
point,
I'm
let's just
gonna
put the
mean.
clothes away.
And I'm gonna
Okay,
lay down
this is
on
a
the ground
reaction to
with my arms
something.
shaking
Okay,
to
we'll
make
get him to
it
the
look like I'm
hospital.
really-
9102. Advise Gold Cross, I believe we have an excited delirium case. I need them here.
Last time when I was, okay, this one's gonna happen, and I'm gonna fart. It's really gonna happen. This is gonna happen.
Tim, it's okay.
And last time I didn't know this was.
Just relax, man. Just relax.
This is really gonna fart, and I'm gonna happen in that hand right there, and I'm really gonna fart in it. And this one, wow. And the heartbeat is coming.
We get two to the back and kind of come in that entrance, officers. Okay, in case we have some movement. I think what we're going to do is if we get those two to the back and get them in here, once we do go hands, they're probably going to have to go to the feet, and then we'll get them on board. We have the medics ready?
Yep.
Okay.
They're at the sideline.
All right. All right, let's move. Okay. All right, just relax. Okay, get the medics up. Let's get him on,
Get the medic
strapped down to the cot. You guys got your medicines?
Okay, take deep breaths.
Are we not going to do that?
I need you to breathe.
Hey, what's going on?
It's alright, man. You're gonna rest. Did you
Did you take it? No, yeah, Narcan and Haldol. Or, yeah, Haldol.
Tim.
Let's do a heplock.
Yeah.
Sure.
Are you just going to do it?
I'm gonna draw it.
I am.
Yep. She said she saw mushrooms in the yard. So
Get on his legs. Lay across his legs.
And why not?
You want to go on a board with him and then strap him and then get him out, or what do you think?
I think if we can wrap him in this blanket.
I just don't want him to get free if he.
Yeah.
Yeah.
Have him get the scoop stretcher. We can do that.
Sure. As long as we can secure it to him.
With straps. Plenty of straps.
I'm gonna grab my balls.
What?
But I gotta grab my balls one last time. It's okay. I can hear this one. It's weird. Even though it's okay, I'm gonna grab my balls. That okay?
Yeah, we got to get you to the hospital.
Isn't that okay? Please,
help you
anti-tap
out.
my hand. Please, anti-tap my hand. Please,
No.
anti-tap my hand.
I'm
Please,
just-
anti-tap my hand.
No, it's okay.
Please,
Don't fight it.
Please, anti-tap my hand. I fought. Please, anti-tap my hand. I fought. Please, and I thought.
We're gonna
Please, and I
get
thought.
you to the hospital.
Please, and I taught.
Relax.
Please, and last time I
Relax.
shook and I taught my. Please, please.
Tim, we're
Please,
gonna-
please. And last time I grabbed my balls and I.
Tim,
Please,
stop.
and last time I grabbed
Stop.
my balls and I shook. Please, and last time I grabbed my balls and I shook. Please, and last time my balls and I shook.
You wanna
Please, and
roll him
last
up
time I
and try to
grabbed my
get him
balls
on
and I
it?
shook. Please, and last time I. Please, and last time I. Please, and last time I.
Over this.
Please, and last time I shook and I grabbed my balls.
Tim.
Please, and last time I shook and I grabbed my balls.
Relax.
Please, and last time I shook and I grabbed my balls and I shook. Please, and last time I shook and I grabbed my balls and I.
Yeah, that's fine.
I'm to the bus, come on, I'm to the bus, come on. I'm to the bus, come on, I'm to the bus, come on. I'm to the bus, come on, I'm to the bus, come on. No, I'm serious. No, I'm serious. This
Like
is
I
what I'm about,
said,
though.
like I said,
No,
if
I'm
you're-
serious.
It's okay.
I'm serious. I'm fucking serious. This is what I'm about, though.
I hear you.
No, but I love you guys, though.
It's okay.
Oh,
It's all right. It's all right. We're doing good. We're doing good.
Don't kill me. Don't kill me.
Nobody's gonna hurt
This
you.
is what I'm about. This is what I'm about.
Nobody's gonna hurt you.
Come on.
Nobody's gonna. Just relax. Lay your head back and relax, Tim. Tim, lay your head back and relax.
Kaboosh.
We're good.
Kaboosh.
Tim,
Kaboosh.
Tim, you're alright.
Kaboosh. Kaboosh.
Tim, you're gonna hurt yourself.
I don't want to die, though.
You're not going to.
Seriously,
We're gonna go to the hospital, bro.
Seriously, though.
We're gonna go to the hospital.
No, I'm gonna no. This is what I'm gonna
Did that break loose?
This is what I'm gonna die, though. No.
Tim, relax.
Tim, relax. It's okay. Yes, it is.
Not okay.
It's okay. It's okay.
Not okay.
It will be okay. You gotta calm down.
Not okay.
You gotta calm down. You
This is
gotta
gonna
calm
die.
down. No, you're not.
This is gonna die.
We're going to the hospital.
This is gonna die. This is gonna die.
We're going to the hospital.
No.
Tim. Relax.
No.
me a
This
favor,
is gonna
man.
die, though. This is gonna die, though.
Remember, your mom's all worried about you. Try to relax so we can help you.
Mom!
That ain't gonna.
Don't let him kill me! I love you, but this is gonna die, though.
Okay.
This one, all the meat I've eaten, I forgive myself.
Are we good on those arms?
This is gonna be it. I'm in a.
Satisfied?
Mom! Mom!
Should I do a handcuff also loose in case? of a safety
You're
mechanism
questioning
from that?
liar! You liar!
All right.
Liar! 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 You're the one! Liar! You're the one!
Let's get him out of here.
Broke his back with a shovel! Broke his back with a shovel! Grab a shovel! We have a shovel in the backyard! Grab a shovel and poke his back out! No! Grab a shovel! Poke
You got it?
I don't want to kill you!
You don't want to kill me?
I don't want to kill him! Okay, I don't want to kill him, but...
We're trying to take care of good care of you.
Me or you?
Oh, no.
After watching that video, you might ask, why not wait it out? Well, there are other emergent conditions that can cause a patient to mimic the behavior of a patient experiencing excited delirium, such as hypoxia, hypoglycemia, trauma, seizures, or other intoxication. Leaving these things untreated could be to the patient's detriment. Furthermore, as I previously discussed, hyperthermia, acidosis, Hyperkalemia and even rhabdomyolysis can occur as a result of the excessive muscle use and breakdown. Treating these conditions early could save the patient's life. Once a patient goes into cardiopulmonary arrest after excited delirium, there is very little chance to successfully resuscitate them. This is why we must take aggressive steps in implementing a treatment plan for these patients. Okay, let's look at the management of the excited delirium patient. For ease of use, I have broken down the procedure into 3 phases. Phase 1 starts by obtaining the proper resources for managing the patient. Most often, law enforcement was probably on the scene first, as the caller suggested that the patient was acting oddly or aggressively. Law enforcement then summoned you for an evaluation of the patient medically. Remember that the patient has superhuman strength and you will not be able to coax them into compliance. Be sure that you have enough people there to hold the patient down so that the paramedic can administer the medication safely. Typically, this is 1 individual for each limb, at least 1 for the torso, 1 who's coordinated the whole effort, and then the paramedic with the medication. While these people are being assembled, evaluate the patient's sample history, most likely through somebody else on the scene. This will give you not only the signs and symptoms, but it'll also let you know if the patient is allergic to anything you might be giving, what medications and history they have, if they have ingested anything prior, and whatever events led up to your visit today. Evaluate the patient for schizophrenia and or bipolar disorder, as these conditions can intensify their mania after the medication is given. Develop a plan. Assign roles to each member of the crew and ensure that they fully understand the responsibilities of their task. The use of electronic control devices can be attempted, but realize that they may be minimally or not effective at all. Some may suggest that the use of these devices may induce cardiac arrest on the patients, but data now supports that they're likely to do better with rapid treatment than they are to be left in this delirious state. Prepare the resources, PPE for each member on the team, restraints on the cot and the backboard, a spit hood if necessary, and the medication, have it dosed and drawn up for that patient prior to the use. Remember, no more than 3 cc's can be administered per muscle, so you'll most likely be administering more than 1 injection. Phase 2 of the management of the excited delirium patient is the execution of the plan. Start by making all communication, both verbal and nonverbal, non-threatening. When you initiate the plan, physically restrain the patient. Administer 5 milligrams per kilogram of ketamine IM, even if it has to go through the patient's clothing. And remember not to give more than 3 cc's per injection site. Wait for that medication to take effect, and then finish restraining the patient to the stretcher and or the backboard. You may want to consider a spit hood and a pillow behind the patient's head if appropriate, but make sure that you can manage a patient's airway if a problem occurs. Phase 3 of the management begins by finishing an assessment and loading the patient for transport. You'll be monitoring the patient's airway, breathing, and circulation, as well as their other vital signs. Consider the causes, including anything you may have found in your sample history. You'll establish at least 1 IV, preferably 2, as you may need to administer a lot of fluid, as well as treat conditions with medications that are not compatible in the same IV line. IV fluid is going to be the treatment of choice for hyperthermia, hypovolemia, lactic acidosis, and rhabdomyolysis. In addition to the fluid, hyperthermia can be treated like any other heat emergency where active cooling is provided. A 12 EKG must be obtained next. This will help us search for signs of hyperkalemia, as well as any other pathologic finding that could result from excessive stress associated with adrenaline dumping. Post-radio considerations for excited delirium may include additional doses of ketamine if continued sedation or dissociation is needed. If you were able to establish an IV, you could request 0.5 to 1 milligram per kilogram of ketamine IV bolus if your patient was coming out of the dissociated state. This most likely will only happen if you have exceeded the half-life of the ketamine, which should be between 15 and 30 minutes after that first administration. If you ran out of ketamine in the box, you could consider asking for small doses of fentanyl, say 25 to 50 micrograms if their MAP is above 65, and 0.05 milligrams per kilogram of Versed. You may need to request additional fluid if you suspect hyperkalemia, acidosis, or tissue breakdown. These findings could be substantiated with the assessment of end-tidal CO2 and lactate. If acidosis is suspected, you could request to give 50 milliequivalents of sodium bicarb over 20 minutes. 1 gram of calcium chloride could be given IV for patients who you may suspect hyperkalemia in. And this could be suspected with patients with peaked T waves. And as things get worse in more severe cases, you'll have a widening of the QRS and the T complexes. Make sure you do not give sodium bicarb and calcium chloride through that same IV line. Another use for ketamine is for facilitated intubation, where you utilize ketamine as part of your paralytic protocol. We do not currently have paralytics in this medical control authority, so we'll have to go with what Ruben Strayer calls ketamine-supported intubation. Ketamine does have direct bronchodilation properties, which will help patients who are respiratory compromised. It will cause an increase in blood pressure and heart rate as well, so caution should be used in patients who have conditions such as a subarachnoid hemorrhage. Big doses are needed for this facilitated intubation, with at least 200 milligrams being needed for a patient of standard size. Also keep in mind, though, that patients who are peri-arrest, ketamine may actually take on a sympatholytic property, dropping what little tone the patient still has. After you have the patient intubated, ketamine can be used to keep the patient sedated or dissociated. In one of his podcasts, Scott Weingart talks about the SPICE study, where patients' long-term outcome is significantly improved with a reduction in delirium and pain post-intubation with ketamine use. The use of benzodiazepines has been linked to longer stays in the ICU, making ketamine a superior choice for sedating these patients. Ketamine also works very well for pain management. 20 milligrams can be administered over 10 minutes and have significant decrease in the patient's pain. Lastly, some physicians are suggesting that administering an induction dose of ketamine, IM, prior to preparing your equipment for intubation on severely exacerbated asthma patients has been shown to improve their condition, enough so that often they don't even need to be intubated. Both pulmonary effects and the reduction in anxiety improve that patient's condition. So to wrap this up, I'd like to go back to the primary purpose for ketamine being added to our pharmacy kits, which is excited delirium. The treatment of a patient with excited delirium can be broken into 3 phases. Phase 1 is where we organize the resources, we create a plan, and we prepare to enact that plan. Phase 2 is where we execute the plan. We physically restrain the patient, we tell the patient to think happy thoughts, we medicate the patient, and finish the restraint process for transport. Phase 3 is where we fully evaluate and treat the causes of the delirium. Also, don't forget to consider the emergent syndrome that the patient may experience when they come back from that dissociated state. I want to take a moment to thank you for listening. I hope you can utilize this in your practice. Please feel free to contact me if you have any questions or comments. Thanks again, and I'll talk with you soon.